for his today's webinar about neuromodulation in severe pain conditions. I would like also to welcome our distinguished panel, headed by Dr. Ayman Hafiz, Consultant Neurosurgery, Saudi German Hospital, Asir, Dr. Dina Nabil Abbas, Consultant of Pain Management in Saudi German Hospital, Jeddah. Just a simple announcement that our program today is 2 hours accredited by Saudi Commission for Health Specialties. Please make sure that you provide your correct email, mobile number, and Saudi Commission registration number to be able to upload the CME hours to your account. Also, I would like to appreciate if you provide your feedback after our today presentation. It will help us to improve our future webinar and to add more interesting topics. Your questions could be raised through chat. It will be collected by the webinar coordinator, and it will be raised during the discussion after the speeches of our distinguished faculty. I would like to now to introduce Dr. Ayman Hafiz, Consultant Neurosurgeon in HGH Asir, to chair and to moderate our today's webinar. Dr. Ayman, please go ahead.
Good day, everybody. Today we have a very interesting webinar about the management or further management of severe pain conditions. Usually, chronic pain is actually a very common and very difficult to treat condition. Usually it is managed conservatively, medicines, slight interventions, but sometimes you are faced with this patient who is not responding to any of our treatments and he is in pain. We have a step further, neuromodulation, lots of other more advanced options, surgical and minimally invasive. And luckily, these treatments are offered in Saudi German Hospital, all the groups, all the branches. Today we have 2 very interesting talks. First, we will start with Professor Alish about neuromodulation. He will discuss it with us. He's one of the world leaders in this modality of treatment. And we have Dr. Dina Nabil. She is a pain management consultant. She will discuss with us Trigeminal Neuralgia, which is one of the really severe pain conditions. The patients should be treated as quickly as possible and as aggressively as possible. She will discuss this with us, and she will give us a quick talk about cordotomy for unilateral somatic pain in the body pain. I would like to give the talk now to Professor Alish. Professor Francois Alish, Professor of Neurosurgery and Functional Neurosurgery in Austria, and he will discuss neuromodulation with us. Please, sir.
Thank you. I have first to share my screen. In order to start, I hope that all is fine now for you, that you see my... Wait a second.
We can only see half the screen. I think this is, I don't know if this is for me only or what.
No. We see it now.
I think for everyone.
All is fine now?
Yes.
I can see half the screen only.
Now it's coming correct.
Okay.
Okay, now it's okay.
Thank you very much for inviting me to this physical distancing meeting. Not social distancing, physical, because it's not social distancing what we are practicing, because I have been in close contact with my colleagues in Saudi Arabia during the whole COVID crisis now. We are in close contact. Unfortunately, we cannot travel, but this is not social distancing, this is physical distancing. And I will do my best to compensate that and to give my lecture here. What is missing a bit is that I do not see the audience. I am talking to my computer monitor right now. I've had a contact with my colleagues in Saudi Arabia, but the interaction is missing. So I have to apologize for this. It's not my fault. This is how it is when you go for a webinar. I've been at Saudi German Hospital as an international visiting professor for almost 15 years. I started in 2005 and I have been repeatedly there. I think there are more than 40 times I've been there, and I go regularly. Unfortunately, COVID-19 stopped this regularity, And we are all hoping that we can soon resume working with my colleagues there. And we have built up a very nice cooperation between different branches there. So Jeddah, Asir, Dr. Ayman, he's from Asir, also Heil, Riyadh, and so. This is great working for the German hospital, and I really appreciate that they, during the COVID crisis, even take the workload to organize something like our webinar now. So I will talk about neuromodulation in severe pain conditions. I'm a neurosurgeon, and I'm perfectly aware that the surgical treatment of severe pain is not the first treatment. I'm not talking about disc herniation. I'm talking about a pain condition that is not related to something coming from neurology or so, but something that has an other reason. And so the very first therapy that we will offer to the patients, of course, is causal therapy. The next step is physiotherapy. Then comes medication. I think medication is a powerful therapy that can be offered to our patients. And then the very last step is surgery. And when you look what we as neurosurgeons, I would say neuro or brain surgeons, can offer to our pain patients is that we can go all the steps up from the peripheral nerve to the hemisphere. So this is all our territory, and we can enter at every point. We can enter at the nerve level, we can enter at the ganglion level, root, tractus, midbrain, thalamus, and even hemisphere. I will tell you how we will do that. So we have, for every level, we have an option for these patients, starting with neurotomy and ending with leucotomy. Leucotomy is not serious, only to tell you at what level neurosurgeons have been active when treating pain. And in between, we have all the other things, gangliotomy, rhizotomy, or mesencephalotomy. All the things that I've written down there can be done by the neurosurgeon. But before going to treat a pain, we have to be well aware about what kind of treatment we are offering. So we have to distinguish between malignant and benign pain. Is the patient a tumor patient and he has pain based on his tumor? That's different than if the patient has his pain based on a benign disease like spinal problems, for instance. So in my talk, I will not talk about malignancies, malignant pain. I will only talk about benign conditions, but nevertheless, I will mention shortly where we can work. And then we have to distinguish between nociceptive pain, neuropathic pain, or mixed pain. Nociceptive pain is the classical pain that all we know, something happens with your hand, with your foot, it hurts, it's painful. Neuropathic pain occurs when the nerve itself or the nerve tissue itself is affected, and it can be mixed as well. And then we have to differentiate between central pain and peripheral pain. The typical nociceptive pain is bone pain, pain of the soft tissue, colic, pain on pressure. And we have the neuropathic pain. This is peripheral neuropathy, plexopathy, even thalamic pain, so very high, zoster neuralgia, complex regional pain syndrome, CRPS, root avulsion, syringomelia, or differential pain after tumor. And we have mixed pain. A big reason for mixed pain is, for instance, post-laminectomy pain. So you have the local problem, the patient has been operated on the spine because he had pain, disc herniation, but due to the operation itself, there was also injury on the nerve, so he has an additional neuropathic pain. So the original pain, which was in fact a somatosensory pain and a neuropathic pain, or post-amputation. You can have, because the nerve is cut, you have a neuropathic pain, but you have also neuroma, formation of neuroma. This is a nociceptive pain. And you have plexus infiltration by tumor, so you have also mixtures there. When you go for malignant pain, you must be aware that these patients have only a reduced life expectancy, reduced general condition, and polymorbidity. So you cannot do everything for these patients. I will focus primarily on the neuromodulation options that we have, but I also mentioned, and I think that Dr. Dina, she will talk more about this, the lesional techniques. We have a lot of possibilities how we can destroy the nerve. We can cut it simply. We can use cryo, so cold. We can use heat, thermo, radio frequency, which is very typical. So this is, I would say, in 80% of the cases, you go for radio frequency. But you can also go for chemical or even radioactivity. There are lots of possibilities, but this is the typical device that we are using at Saudi German Hospital. This is an old one, but a very good one, very powerful. And I've been using this machine for many, many years. And in each place in Saudi German Hospital where I'm visiting, we have such a lesion generator. Of course, you can do it with radiosurgery. I'm not talking about this, I'm only mentioning. And you can cut the nerve. I think that Dr. Dina, she will talk about trigeminal neuralgia. This is nothing for neuromodulation. I will skip that rapidly. This is a typical rhizotomy. And in patients with malignant tumors, you can also go for a peripheral rhizotomy, for instance, with a chemical rhizotomy. I will not mention this. And she will also talk about chordotomy. I will not talk too much about this, but chordotomy is nothing else than cutting at the level of the neck, C3, C4, and to go for a lesioning of the spinothalamic tract. So you simply cut the pulses coming from the periphery, from the malignant tumor, for instance. But you can go also higher. You can go to the mesencephalotomy. There have been many surgeries described about this, many techniques. This is more historical. This only to show that we as neurosurgeons, we can go to every step, to every level. And this is no longer practiced today. What is very interesting, unfortunately, this is done far too rarely, is the rhizotomy. The idea of the rhizotomy is that you cut the nerve coming from periphery, entering the spinal column and the cord, spinal cord, and you go to the substantia gelatinosa. This is a filter that avoids that the painful pulse coming from the periphery enters the spinal cord and goes up to the thalamus. I think the rhizotomy is a fantastic therapy to treat a peripheral neuropathias, neuropathic pain. I think this is very, very good. And I'm showing you that not to go more in detail, because this would fill another hour to talk about this, but I'm showing this because I will come back to that later when talking about neuromodulation. And then my primary interest in medicine is therapeutic and functional neurosurgery. We can even go higher. We can go to the thalamus, which is the integrating part of the brain, where all the inputs are coming from the periphery, going to the thalamus, and have a projection to the cortex, and then they go down to the motor part. And the posterior part of the thalamus is also a relay for pain. And you can go via thalamotomy, for instance. You cut the pain. This is fantastic, works immediately. Or you can go, and I will later, when talking about neuromodulation, will show you that we can also stimulate there. This is a classical thalamotomy. But the drawbacks of ablation, and this is what I showed you, all what I showed you now was ablation. The drawbacks are, it is irreversible. So you have to decide at the moment when you are in the UR, you have to decide how far I'm going. If you go too far, you risk side effects. If you go not far enough, you have a recurrency after. It's not adaptable. So typically the lesion therapies that we are offering are not adaptable. And it is the major drawback of this. The advantage is it's instant effect, but it is no further actions required. But the disadvantage is that often it's only unilateral, and you have the disadvantage that you can damage adjacent pathways. And you can, of course, I think it's very important to mention, when you cut a nerve, immediately the pain is gone. But in the future, there will be a deafferentiation pain. The likelihood that the patient develops a deafferentiation pain after cutting a nerve is relatively high. And so this brings us to, in fact, the topic that I have to talk today, to a non-lesional option for these patients. I've been talking now about the lesional therapies, neurotomy, gangliotomy, and all the things all the way up to the brain, but we have also something as an alternative, which is not destroying, which is not cutting, simply augmenting activity, simply filtering, and we call it augmentative or stimulation. And you can, in the same way, then you go from neurotomy to leucotomy, you can go from peripheral nerve stimulation up to motor cortex stimulation. So on every level of the nervous system, you have one possibility as a neurosurgeon or as anesthetist. So a lot of these therapies are done today by anesthetists. You have a lot of levels where you can interfere. And this is what we are experiencing today. I think this is now since 20 years, we have seen a steady increase of these therapies, and now it's really becoming very, very active. So there are several companies on the market. The classical, so Medtronic was one of the first coming out with systems for neuromodulation, but there's Boston Scientific, Abbott, and there are so many small startups at this moment, companies who come now with new technologies, and we will see a lot of things in the future. And when I talk to students, I always say, when you want to become a neurosurgeon, or when you are now in the process of becoming a neuro doctor, so to say, please have a look on this, because there are so many opportunities for treating patients, not only for pain. We are doing this therapy also for Parkinson's disease. We are doing it for movement disorder, all kinds of movement disorders. We're doing it for epilepsy. So I think there are so many. You see here on my slide is also in psychiatry. Also in psychiatry, there are startups coming with new possibilities that you can use for this, even in dementia. We'll take another hour to talk about dementia, for neuromodulation for dementia. I think we can expand that endlessly, but I will try to focus on my pain, because I think this is my topic. We are talking about technical neuromodulation. There's another way to neuromodulate. This is the pharmacological. I'm only saying that because I'm afraid that somebody will mix that. If I talk about neuromodulation in this talk, I talk about neuromodulation. Neuromodulation, defined by the International Neuromodulation Society, is an alteration of nerve activity through the delivery of electrical stimulation or chemical agents. So when you implant a pump, we'll not talk about the pumps today, you will also neuromodulate to targeted sites of the body. It's carried out to normalize or modulate nerve function. So this is the reason why we call it neuromodulation. And the most prominent kind of neuromodulation, of course, and many of you will know it, is spinal cord stimulation. Spinal cord stimulation is used to stimulate in a level of the spine. You can use it at the peripheral side, so even stimulate the nerve, but you can also go to the sacral side to stimulate the sacral nerves. You can stimulate at the lumbar level, you can stimulate at the thoracic level, you can stimulate at the cervical level. So you have all the way up the possibility to stimulate. I will explain you now how this works and also what is the theoretical background of this. It's a relatively easy procedure. You see it on the left side. You see it's a percutaneous puncture. you puncture, you go to the epidural space, and then you advance your electrodes and you put them on the epidural space. And according to the level that you want to stimulate, you put it on different levels. But the classical spinal cord stimulation that was introduced, it was the very first neuromodulation, by the way, that was introduced. This was mid-60s, and this goes back to the gate control theory. This was Ronald Melksack and Patrick Wall who described this in Science in '65, and they observed, as that was their theory, and it's a good theory, by the way, they said that when the pulse from the periphery is entering the spinal cord, it comes from behind, because it's the posterior part. It comes from behind, and there's the first synapse. This is the first point where the relay is. And this is what I showed you. I showed this already earlier. This is the substantia gelatinosa, what you are cutting when you go for DRAWBACKS. They are not going for DRAWBACKS, but they simply put an electrical wire. So a lead, today we are doing it with lead, an electrical wire on this place, and they disturb this path from the periphery to the brain at this level, because the substantia gelatinosa is very open for being disturbed. And when you disturb it, or when you cut it, so still Melksack and Wall, they were talking about lesioning. This was the idea behind. But you can do it the same way, and this goes back to Norman Shealy and Thomas Mortimer. They said, we do not have to cut it. We simply can put some noise on it. Today we would say we simply put noise on it, and we try to avoid that the painful stimulus coming from the pulse from the periphery passes through and goes up. This was the idea. And they put an electrical wire on this place, epidural. No, first they went intradurally, but this is not well tolerated by the patient because it's very painful. And then they put it epidurally, and they were calling it dorsal column stimulation, which, by the way, is more precise than spinal cord stimulation, because dorsal column stimulation says that they are stimulating the posterior part of the spinal cord. Spinal cord stimulation is a bit unspecific, but it is the way how we call it today. And this is the material that they were using at that time. They were using external pulse generators, so they didn't have implantable ones. They were using external pulse generators. They had a one contact electrode that they were putting on. It worked. It worked. Today we have systems that work with 32, even more contacts. It works better, yes, but it is not a big difference. And so we saw in the 70s, 80s, no, by the end, it was in the 80s, we saw the first system that could be implanted. This was a Medtronic pulse generator. This was a programmable, implantable pulse generator, meaning that the whole system was under the skin, the whole system was implanted, and the stimulation came from this inbuilt battery with one contact. This device was one contact. And this should show you what happened after. So there was a big market after. Science followed the money finally, or money followed the science. And so there is a huge development now at these days. And we see more and more systems coming to the market, and they are more and more easy to handle, easy to place, easy to follow up, because it's also very easy for the patient. They have some kind of external device. Some use an iPad from Apple, and they can adjust the stimulation level. It's very practical for these patients. And so we can do this therapy, I said it already, at many levels. It's a bit depending what electrode are you using, but typically it's done percutaneously. We puncture, we put the electrode in, and we can treat all these types of pain that you see here. Neuropathic pain, So this is damage disease to somatosensory system. This can be a radiculopathy. This can be a complex regional pain syndrome. This can be failed back surgery syndrome. I think this is the most important. Failed back surgery, this is really the highest rate where we are doing spinal cord stimulation. These patients are still in pain. These patients have some damage due to surgery or due to their implants that they have. And so these are the typical candidates today for spinal cord stimulation. Differentiation pain is more rare, but we see them also. This is stump pain, phantom pain, and of course, spinal cord injury. This is also one of the types that we are operating. And then peripheral nerve injury with aberrant regeneration, spontaneous pathological activity. And what is very important is also ischemic pain. This is peripheral problems. This is peripheral vascular disease, PVD, and it works extremely well in refractory angina pectoris. It's a bit crazy. Somebody has angina pectoris and you're, instead of implanting maybe a pacemaker for the heart, no, you implant a system for stimulation. The reason is that there is a small number of patients that suffer under angina pectoris were well treated. All is fine, but they have still pain. The pain is very much localized around the heart. It's a very clear level, and you can help these patients because you put an electrode at this level. You can do it blindly. You put it and you stimulate and the pain is gone. You will not cure the patient, but you will improve the life quality because you can take away the pain, and the patient is enough diseased already with the heart. He should not be diseased by the pain. And I think this is the reason why I think that ischemic pain of the heart is by far too seldom operated with spinal cord stimulation. I think this works really fine. You can also use the spinal cord stimulation not off-label, but off-locus, so to say. Then you go and you put the system directly to the nerve. This is peripheral nerve stimulation. This is, for instance, for severe migraine or cluster headache. This is how it's done. I don't like it this way because the problem is when you implant it like here, you have the problem that you have a relatively huge pulse generator and you have the electrodes going all the way down from the occipital nerve to the pulse generator. And there's a lot of possibilities that the electrodes break. And there are better options today. You can have a very small electrode that is remotely linked to an external stimulator. Very much that what we did in the past before we had the implantable pulse generator. And then there's another thing that I want to share with you. It's the most recent kind of neuromodulation in pain. And it's interesting that it came so late because we know that the dorsal root ganglion is a very important relay in the path of the pain coming from the periphery. Nobody was thinking about stimulating there. The reason is that it's very painful when you stimulate. So when you stimulate it, you have to go very low. But the other reason is nobody was thinking about this. And there was one company coming out with a system. They were using this for complex regional pain syndrome. I think this works very well in CRPS. CRPS, you know, this is very intensive pain with hyperesthesia, hyperalgia, allodynia, sensory deficit, and also with autonomic signs like swelling and also color temperature changes and sweating abnormalities. This is how it can be diagnosed. You look at the skin temperature. So when you have a CRPS at the upper limb, you can show it wherever, but this is now showing it at the affected limb that you have a difference in temperature. And this is a very tricky thing because you have to go to this ganglion. And it's not easy to reach. So I think this is a bit tricky to find it because it's not only putting the electrode in the epidural space, but you have to put it in the epidural space. And then you have to go and to find the ganglion. And this is the video. I hope that the video works fine, that you see. You come from the contralateral side, and then you advance the electrode, which is a four-polar one. This is plenty enough for this. And then you make a small loop. You see that this electrode is now already in the channel around the ganglion, and you make a small loop in order to make sure that it does not flip out with the first movement of the patient. And so, yeah. So I think this is a very powerful therapy as well for treating CRPS. It's better than spinal cord stimulation for CRPS because it's even going more directly to the ganglia. So far for SCS, I will I think I have already a bit, have been long. I would simply mention that we can even go beyond. I mentioned it earlier already. We can go to the brain. This is something that I personally appreciate very much. This is not for everybody. This is for persons who are really suffering from severe, and it's important, from severe pain where nobody else can help. Then the stimulation of the thalamus can be a very, how to say, a very comfortable, a very easy, and also a very stable treatment. Because unlike spinal cord stimulation, where the electrode can move all the time because the spine is very mobile, in the depth of the brain, nothing is mobile. When the electrode is on the right spot, we are doing this with stereotactic means. When the electrode is on the right spot, all is fine. And to stimulate directly this part of the thalamus where the pain is coming to. And here you see typical situations. This can be a lesion for the central pain. This can be a lesion inside the thalamus, or this can also be a lesion inside the projection between the thalamus and the posterior cortex. Here you have a related picture from MRI. These are two different patients where you see on the left side a thalamic lesion, and on the right side you see a thalamocortical lesion after a bleeding. This is how it looks after implantation. So typically this is a unilateral pain, because when you go there, it's typically patients that have a unilateral, well-localized pain. The thalamus is very precise. You know that the laterality of 12 millimeter, you come to the face. At 13 millimeters, you go to the upper limb. And if you go even more medial, you go to the lower limb. So it's very precise, but if you hit the target, it's a fantastic way. These are the indications for deep brain stimulation in pain. We are, of course, we are doing this in the majority of the cases in movement disorders. This is where really the business is, where a lot of patients are implanted. But this is now the indications for pain, and they are very similar to the indications for the spinal cord, but it's only a matter of level. If you go higher, you are more precise, but you reach also regions that you would not reach, for instance, in the face with spinal cord stimulation. And you can go even above that. Personally, I'm not a friend of motor cortex stimulation. That's been described by a Japanese group in the 80s, 90s. This is the idea is that you put the electrode not at the thalamus, you also neuromodulation, you go directly to the motor cortex. Now, those who are attentive now would say, what? The motor cortex, this is not for pain, this is for motor. Yes, this is true, but you cannot stimulate the sensory cortex because the patient will never tolerate this. This would be extremely painful. So you would try to treat the pain with pain. It's not possible. But we know that there are connections between the motor cortex and the sensory cortex, and this is a NUS. So when you go to the motor cortex, the effect that is flipping to the sensory cortex is a NUS. So this is how it works, and it's relatively easy. This makes it quite popular because you only make a borehole and you implant an electrode like here. This is a plate electrode that you can input here. So at the beginning, I wanted also to talk about intrathecal drug administration, but I think I'm largely overdue already. And I come to my conclusion saying that neuromodulation is very effective, is adaptable, is reversible, and has a lot of innovative power. Something is missing here. I have to add it. I was not talking about that because this will fill another hour, is expensive as well. So probably some of you will ask after, what is the price? It's much more expensive than the therapy when you go for lesional, but it is adaptable and the price does it then. So I thank you for your attention, and those who have questions to me can easily contact me with my WhatsApp, business WhatsApp, which is only text only. You can write it in Arabic. Google will translate it for me. I will answer you. And so I think I'm done now. And I'm really eager to hear your questions. Thank you.
Thank you, Professor Alish, for the interesting presentation. Thank you very much, sir. I think we now have Professor Hassan Gaber with us. Am I right? Is Professor Jaber with us?
Actually, he is out, Dr. Ayman, again. You know, Dr. Jaber, I think he is in a home quarantine now. We would like to wish him a quick recovery and to get well soon with the rest of the team in the neurosurgery department. So we can proceed, please, with the webinar. Thank you.
Okay, Dr. Dina, we will have a nice talk about trigeminal neuralgia, I think. So would you like to start? You need to share the screen with us?
Yes, please. Appearing?
Yes, absolutely. Please go on.
My talk will be about radiofrequency techniques, basics of radiofrequency. Radiofrequency current is low energy, high frequency, alternating current. When applied to biological tissue, this current causes charged molecules to oscillate with rapid changes in alternating current. The resulting frictions in the tissue produces heat. Two types of radiofrequency application can be used: continuous radiofrequency generating a lesion, or pulsed radiofrequency in the form of bursts. No lesion is formed. It is a sort of neuromodulation at the level of the dorsal root ganglia, at the level of the dorsal horn, at the level of descending inhibitory pathway. So pulsed radiofrequency affects cell function with minimal destruction, while radiofrequency conventional or thermal, it does produce a lesion. The radius of the lesion ranges from 2 to 5 millimeters. Now there are new concepts in pulsed radiofrequency. It may produce anti-allodenic action when we increase the duration to 6 minutes. Advantage of radiofrequency. Radiofrequency lesion over other neurodestructive methods. The lesion size can be adequately controlled. Good monitoring of the lesion temperature can be performed with a thermal coupled electrode. The ability to utilize the same RF cannula for different types of lesions can be performed under local anesthesia or conscious sedation with rapid recovery, low morbidity and mortality, and the ability to repeat RF lesions if the neural pathway regenerates. The disadvantages: unwanted boiling if temperature increases, non-reliable for large nerves, neuritis or neuralgia, which may occur, sensory or motor impairment. My talk will be about trigeminal neuralgia, which is a painful unilateral affection of the face characterized by brief electric shock-like lancinating pains limited to one or more divisions of trigeminal nerve. Pain is evoked by washing, shaving, smoking, talking, brushing, air blowing, or can occur spontaneously. Pain is abrupt in onset and may remit for varying period. Trigeminal nerve is the largest cranial nerve connected to autonomic nervous system via cranial nerve 3, 7, 9 and to otics, phenopalatine, submandibular, and ciliary ganglia. It carries sensation from the face, the teeth, gums, oral mucosa, anterior 2/3 of the tongue, anterior and middle cranial fossa, proprioception of extraocular and mastication muscles. Anatomy of trigeminal ganglia. It is related medially to the cavernous sinus with internal carotid artery and the cranial nerves 3, 4, and 6, posteriorly to the CSF cistern and brainstem, superiorly to the temporal lobe, anteriorly to the branches. We have 3 nuclei and the 4th motor nuclei at the level of the medulla, pons, midbrain, and the pons, the motor nuclei. The peripheral nerves appear through ophthalmic, maxillary, or mandibular. They emerge from the cranium through superior orbital fissure, foramen rotunda, foramen ovale. So this is the Gesserian ganglia or trigeminal ganglia, and these are the branches.
Dr. Dina, you are mute. Can you unmute yourself, please?
Okay, I think we have Professor Hassan Gaber with us now. Professor Hassan, most welcome, sir.
Welcome. I was with you actually, just like I was doing in the elevator, so disconnected and connected again.
Okay.
Yeah.
So Professor Hassan Gaber is the head of the department and the consultant neurosurgeon in Saudi German Hospital, Jeddah. Most welcome, sir, and we wish you the best of luck. Get well soon.
Thank you, Dr. Ayman. Thank you very much. Yeah, thank you.
Thank you. So, Adina, sorry for the interjection. Would you please?
Dr. Hassan.
أهلا دكتورة دينا. أهلا بك. حياك الله.
I am speaking about the trigeminal neuralgia, which is unilateral orofacial pain. The pain distribution of trigeminal nerves branches. When we have these symptoms by history, it is possible to be trigeminal neuralgia, but we have to do interview and examination with the patient. So when pain is triggered by typical maneuver, this probably trigeminal neuralgia, because the diagnosis is essentially clinical. When we have tests to confirm it, the etiology is possibly definite trigeminal neuralgia. If this is not confirmed, so it is idiopathic trigeminal neuralgia. If MRI confirmed neurovascular compression, it is a classic trigeminal neuralgia. Or if MRI found any major problem, it's secondary trigeminal neuralgia. The most common is idiopathic trigeminal neuralgia. Diagnosis: no medical test is available to confirm the diagnosis. Diagnosis is made from clinical history. Some consider the carbamazepine as diagnostic. Cranial MRI is needed to rule out secondary causes. 14% of trigeminal neuralgia may suffer from intracranial tumors. The treatment is essentially medical. Surgical treatment if medical treatment fails or side effect or cannot be tolerated. The choice for management of trigeminal neuralgia varies from microvascular decompression, gamma knife, percutaneous radiofrequency, trigeminal rhizotomy, percutaneous balloon compression, glycerol rhizotomy, or tractotomy. The choice of treatment depends on the cause, the age of the patient, and many factors. First, before we do trigeminal neuralgia, RF for trigeminal neuralgia, we have to set the room, we have to prepare the setting of the room of the arm, the technician, of the anesthetic. Everyone has his own role. We have to prepare the patient. There are 3 landmarks we prepare: the middle aspect of the pupil, this line, and 3 centimeters from the ear canal, and 2.5 centimeters from the angle of the mouth. This is the trajectory, our needle. The patient is in the supine position. The head is the arm in the submental view. Target the foramen ovale. This is the ramus of the mandible. This is the orbit. We have to search on our target here. This is the foramen ovale. We can place a finger on the lateral pterygoid plate to guide our trajectory. To slide the cannula along our finger lateral to the pterygoid. The cannula ends in the line between the pupil, passing through the pupil of the eye, and the line from the tragus. The intersection of this line is our trajectory. In the lateral view, we should know the anatomy. This is the clavus. This is the petrous part of temporal bone, and this is the foramen ovale. Again, this is the petrous part of temporal bone. This is the clavus, and this is the foramen ovale. This is our needle reaching to the target. Variation in the trajectory of the needle may result in injury of carotid artery or passage in false passage to the jugular foramen or inferior orbital fissure. So this is the needle. This is the internal carotid artery. The depth of the needle depends on which division we are targeting. And we can use special needle to change the direction, so we can target 3rd division or 2nd division, which are the mostly targeted division for trigeminal ganglia ablation. Then stimulation is done. If we find the stimulation at 0.1, so our temperature shouldn't increase more than 60 degrees for 60 seconds. If it's stimulation at 0.2 to 0.3, we can raise the temperature. Stimulation more than 1 volt, we have to do reposition of our electrode. Complication of trigeminal ganglion ablation. Jaw weakness occur in 7% of cases, absent corneal reflex in 3% of cases, temporary diplopia in 1%, inflammation of the cornea in 0.6%, anesthesia dolorosa in 2%, and it is actually very, very distressing to the patient and to the physician. The numbness is not a complication, it is expected outcome for pain relief. So we should tell our patient that he will experience facial numbness, and he should accept this as a sequelae of the ablation. Accurate diagnosis is essential. Diagnosis is made by history. We have to be optimistic and care and listen to our patient. There is no best procedure for the patient. Treatment should be individualized. Medication should be first tried. Dysesthesia may occur with all ablative procedure. Dysesthesia is not responsive to additional ablation. So if our patient experiences dysesthesia, we shouldn't do ablation again. The outcome of treatment worsen with chronicity. Repeated microvascular dissection has great risk and less success rate. The evidence for trigeminal ganglia ablation is to be positive. So it is recommended to be done with thermal or conventional RF. For the pulsed RF, it is to be negative, so not recommended, but there are recent researches about the efficacy of pulsed RF for trigeminal post-herpetic neuralgia. So science is changing, and the evidence appear to change in the next year. And this is a meta-analysis reviewing the efficacy of radiofrequency ablation, and it recommends to do combined pulsed and thermal radiofrequency for trigeminal neuralgia. Another type of neuralgia is glossopharyngeal neuralgia, which is characterized by severe pain in the side of the throat and it can extend to the ear. Diagnosis is essentially by history. Usually we find the patient seeking advice at the neurophysician, at the surgeon, and the ENT doctors. He responds to xylocaine infusion or xylocaine spray as the pillar of the tonsil, usually relieve his symptoms. Such patient can benefit from radiofrequency pulsed RF to glossopharyngeal nerve, just lateral to the styloid process. Sphenopalatine ganglia block is another block can benefit many patients because the sphenopalatine ganglia has many connections with the sympathetic and the parasympathetic nerves, and has many connections with other cranial nerves. So it is reported to give benefit for cluster headache, migraine, trigeminal neuralgia, herpes zoster, cancer of head and neck, paroxysmal hemicrania, facial pain, complex regional pain syndrome, temporomandibular joint disorders, nasal contact headache, vasomotor rhinitis, and fibromyalgia. This is the site of sphenopalatine ganglia in the pterygomaxillary fissure. Again, in the pterygomaxillary fissure can be simply blocked diagnostically through the nose with the local anesthetic infiltration by a piece of cotton to reach this site, or can be done by fluoroscopy guided in the lateral view in the shape of inverted vase, and in the AB view to reach at the lateral wall of the nose. Still, a ganglia block can be beneficial for many painful conditions, vascular disease, and for neuropathic pain, for herpes zoster, for phantom pain, post-radiation neuritis. Cordotomy, simply it is a lesion in the lateral spinothalamic tract at the level between C1 and C2, done CT guided with special types of needles to do a lesion in the spinothalamic tract after injection of dye to be able to delineate it, guided by the impedance all through as we enter the CSF, then enter in the spinothalamic tract, the lesion, the impedance changes, and we do stimulation for the patient. It is indicated for unilateral cancer pain below the level of the clavicle, like the lung, mesothelioma, pelvic bone, muscles. The success rate is up to 95%, but the patient should know that he will lose the pinprick sensation and the sense of temperature. Stimulation is done at 50 Hertz for sensory and up to 100 and for motor for 2 hertz. The lesion is at 70 to 80 degree for 60 seconds. We can do multiple lesions. Frequency. Key point, all facial pain is not trigeminal neuralgia. There are no tests for trigeminal neuralgia. The wrong diagnosis leads to wrong treatment. And despite all advancements in medicine, it is not possible to cure all pain problems. Best approach for pain management to be multimodal and multidisciplinary. And we have to do proper diagnosis and do not do much invasive procedure type of pain. As long as we feel pain, we are alive, but when we feel pain of others, we are human. Thank you.
Thank you, Dr. Adina. Thank you very much. Professor Jabir, any comments from your side?
You know, I listened to both lectures actually. They're both comprehensive. Dr. Alish's lecture is very comprehensive and enlightening actually. I appreciate Professor Alish. Thank you very much. Dr. Dina, actually your lecture about trigeminal it covered the subject and techniques and so. It's good. It's very good. Thank you very much for it. And yeah, it's a good lecture, very beneficial and educating. Yeah, thank you, Dr. Ayman, as well. Yeah.
Thank you, sir. We have a question, several questions actually now from the audience. The first question is, what is the best treatment or treatment strategy for post-traumatic temporomandibular pain? Any comments?
Traumatic post-mandibular pain?
Post-traumatic temporomandibular joint pain.
TMJ.
What type of trauma we want to ask?
Well, that is the question we received now. So post-traumatic temporomandibular joint pain.
Probably the treatment of the cause is the best option. Then if cannot be corrected, injection can be done to the joint. And
yes, I agree with you. I have a comment here, if you would allow me. I think that, as Dr. Adina said now, that the treatment of the cause. So if you have such a patient, you have to define the cause of the pain. What is actually causing the pain? So I would go for testing the occlusion, because sometimes there is previous trauma, you get malocclusion. Test for the occlusion and do a dynamic MRI of the joint, open and closed. And then most probably you can reach a fair idea about what is causing the pain. As in pain management, you don't always reach a diagnosis. And if that cause defined, that can be, if the cause can be defined, it can be treated, attempted to be treated. If not, then I think Dr. Adina can suggest what kind of injection we do afterwards.
After if we cannot reach the diagnosis of the cause, if we cannot reach
the usual situation, yes.
Injection to the temporomandibular joint itself can, the form of anti-inflammatory, can relieve the in order to cut the pain circle to me.
Absolutely. Okay, I have a personal question now for our panel here. What would you do for a patient with post-brachial plexus injury with complex regional pain syndrome? He received the sympathetic block and sympathetic radio frequency with good result, but short term, 4 to 5 months pain relief, and then the pain comes back again. So that is resistant CRPS. So what would you do next?
Actually, according to the stage of complex lesional pain syndrome, the stage of inflammation, we can give anti-inflammatory drugs play an important role. Vasodilator may help, anti-neuropathic may help. The intervention symptomatic can be repeated and done by radio frequency. Repeated cannot be helpful. I think the spinal cord stimulation, Dr. Alice can play a role. That is why complex regional pain syndrome better to be prevented than treatment. Early detection is very important. It is a challenging condition. It should be always kept in mind when we have a patient with neuropathic pain, if the pain didn't respond after surgery or after injury. It should be treated from the start early. All modalities of
maybe Professor Alish can help in that. You see, you can do the parasympathetic injection or lesion. So it's very helpful in some causalgia and plexus pain if you go to the parasympathetic chain.
If this works, then this is test also for DRG. I think this is what is typically done after. If the pain recurs and was well after injection, I think this can be considered as a test for anticipating the result of a DRG. I think the problem is that we are always going to one path finally, coming from the periphery and going up. And so it's more or less equal where you enter that. So you can do it on the level of the ganglion. You can do it with spinal cord stimulation. So when it's in the face, you will not do a spinal cord stimulation, of course, but you can. They are all competing, these methods. But especially when it comes to the face, I think this could be an option. But the question is only where are you? What is the level? Is it coming from where? Or finally, then deep brain stimulation is an option. Deep brain stimulation has one very strong point. This is facial pain. And we did this with really good results, but we had also the experience, that this is what you said earlier, Dr. Ayman, is when the patient is coming with this, you have to do everything that can be a curative treatment. And when you are thinking about the joint, when you are thinking about any other reasons, we have had a lot of patients that came to us and were asking for deep brain stimulation, and then they went back to the maxillofacial surgeon, and he said, no, I can't cure this. I can't fix that. I think this is always a multidisciplinary venture. We must be aware of this, but if the group says finally, I can't do anything except a neuromodulative technique, then we do it.
Mm-hmm. You know, one of the tests you can do as well is especially for the lumbosacral plexus, is the injection of the ganglia, sympathetic embarrassment of the ganglia with mercaptan. Mercaptan can paralyze the ganglia. It could be a test and could be curative for some people as well.
Is it available in Saudi Arabia now?
Mercaptan, yeah, I used it a couple of times in some difficult patients, and it was available. In the military hospital, it was available.
Then you can help us getting some of this, because we have a couple of patients here that can benefit of this.
Yeah, I know. Some drugs, like, you know, they appear and disappear. You have to chase, like, to be updated with them. Yeah.
Yes, I didn't know it's available in the Saudi Arabia. Okay.
Can I go back to the TMJ? Dr. Dina was right. Like, you know, if there is a fracture, different from dislocation, different from muscle tear, different from disruption, it should be treated, as Dr. Alish said, with the original surgeon. But anyway, later on, local injection, and there is certain exercises they do to the muscles, masseter muscle, and in some patients with local injection and some steroid and exercises, the pain goes away, and once goes away, it never comes back. But some of them, it becomes chronic, you know.
Yes, that's why we have to try to the patient rapidly in order not to change to a chronic. But if we have such cases, we will do repeated injection in an attempt to cut the pain circle and with drugs may help.
Intra-articular injection, yeah.
Yes.
I think they have surgery for some cases. They cut the condyle. It's maxillofacial surgery, like, you know, they cancel the joint, kind of, in a way.
Professor Elish, I have a question, one more question for you, please. For intractable pain, what is the place of stereotactic cingulotomy now? Would you choose a stereotactic cingulotomy, bilateral cingulotomy for patients with malignant pain, or you directly go for DBS or something like this?
No, I would not advise that. I think
I'm talking malignant pain now.
Yes, cingulotomy is not the way. I think it's an option, but you must be aware that when you do a thalamotomy in a pain condition, you have always the risk to have a severe differentiation later. So it's very much like for the cordotomy also. You have to respect time window that you still have the lifespan. And if you expect that this is a person who will live for another 5 years or something like that, I think it becomes very risky to go for a lesional therapy, especially because we have an option that stimulation. But on the other hand, it works fine. It works fine. You can also do it with radio frequency, not with radio frequency, with radioactivity. So you go for gamma knife, but then you with gamma knife, when you make a necrosis, it takes months to react. But
yes, gamma knife will take some time to.
Yes.
You know, gamma knife is becoming nowadays really a good tool for certain pain. Can do ablation, like, you know, the trigeminal. But, you know, the thing is that you need a cooperative radiosurgeon, because some of them like, you know, because they have more important and only very few centers, like in Jeddah one center, and they are busy with other things. But I think it's a good solution for some lesions, even thalamotomy and other things. It's very precise and it goes to the point.
Yeah.
Okay, we have a question here now about breakthrough pain. Cancer pain with breakthrough pain. So I think we would like to know the treatment strategy for this.
Breakthrough pain is either should be differentiated from end of dose pain. Breakthrough pain is a pain in a previously controlled pain. Yeah, I
Yes.
mean, the patient who have a pain controlled, his pain controlled, but he experienced sometimes of exacerbation of his pain. So history is very important. If this pain is just end of dose because of end of his treatment, or if it is incidental pain, the patient experienced the pain when he is moving or doing dressing or doing extra activity. So we should manage this pain with drugs has rapid onset and short duration, and then recalculate the drugs and readjust the doses of his opioid.
Okay. Professor Elish, what is your reflections regarding the future for neuromodulation then for chronic pain conditions, especially spinal pain, with the new advent of high frequency stimulation and remote controlling the devices? So what do you think the future is holding for us?
I was not talking about the different pulse waves and also the frequencies. I think this would be too long. I have 30 minutes to talk. And so I think this is a lot of innovation there, and we will see a lot of things in the future. But we have also to consider that this is a patent issue. So the different companies have different patents, and they, of course, they promote what they have. And personally, I prefer having patients who have low frequency stimulation because you can really, you are really sure that it works, that the electrode is on the right spot. But there are others who perfectly can cope with that, that the patient, when you go for high frequency, the patient does not experience any sensations. The patient has only less works, that feel comfortable with this. I think it's too early to give a final judgment about this because the business at this moment is very fast and we see a lot of new things, and this is very expensive. But the good thing is that the more companies are coming to the market, the lower will be the prices. So I think the availability of these systems will further increase because this is not so much high priced anymore. But this is a field that is under development at this moment, and we will learn a lot of this in the next years.
Yeah. There is one thing is becoming widely spread in North America nowadays. I don't want to promote it, but not as Professor Alish classified them neuropathic. It's not for neuropathic pain, but for the dull aching pain from joints from different places. Now they're using the cannabis, but after separating the narcotic side of it. So now it's becoming really acceptable for all rheumatic pains, joint pains, dull pain. So it's still not allowed in many countries, but it has some response in North America. But not neuropathic pain, but could be used for diabetic neuropathy sometimes, some of them. Some patients report that they are doing well. I don't know, they're just feeling well or they're doing well.
I think something that is rarely addressed when we are talking about surgery is the availability the possibility to drive a car. We are prescribing so much medication and nobody is asking really what's about the license now. Because when I take a strong drug against my pain, I will not drive anymore the car. So I think this is something, when you say cannabis, did I hear correctly, cannabis? It's over. It's not allowed in my country either. But we must be very careful when we prescribe that as a routine pain.
No, not for neuropathic pain. For some of the patients, they come, they just have pain everywhere. Like you do this joint, you do the other joint, you do the other limb, you do the other whatever. I'm not talking about neuropathic or traumatic or spinal cord.
You will never prescribe an addictive drug. Finally, which is I don't think that
they separate two components. They separate the narcotic part and they have the other one which is kind of effective. Anyway, just like side talk, it's not really part of the neuromodulation.
No, it's not even not chemical neuromodulation.
Yeah, it's not part of it anyway. It's psychomodulation.
Okay, thank you. Sorry, Professor Gary.
No, just to say psychomodulation as well works for some patients as well, like because they, whenever they have pain, they feel kind of depressed or anxious, and the other way around. If they are anxious and depressed, they feel the pain more. So parallel to all the treatment we are talking about, I know it's not modulation, it's not intervention. I'm talking about it helps sometimes to reduce the amount of the intervention in these patients.
This psychosocial management is very important, and I think before doing any advanced procedure for any patient, we have to address the psychosocial element of the patient, and the good patient selection is very important.
Yeah, it's vicious circle. Pain causes depression, depression causes pain, pain causes depression. It's vicious circle. You break it somewhere, and you both use both of them so you reach faster results. Yeah.
Okay, to wrap our meeting up, I will ask our speakers if they have any comment before we close. Professor Alish, any comment?
Yes, I see that we have at this moment 421 participants. I'm really excited about this. I think it's fantastic. And the number stays stable, so they did not sleep. So I hope that we have been very informative, and I look forward coming back to Saudi Arabia.
Yeah,
Most welcome.
waiting for you, Professor. Could you send us the lecture, please, if you don't mind, both of you, WhatsApp or email?
Yes, we'll do so.
Yeah, so we can read it slowly later on. Yeah. Dr. Dina, yeah. So.
Dr. Dina,
Yes.
any comments?
Thank you for this exciting webinar. Thanks, Professor Alish. And I hope that everybody enjoyed our lecture.
Yes,
well, I enjoyed it. I enjoyed it myself. Okay, so I would like to thank our audience, and I think the one point to stress at the end of this interesting talk, that there is always another step to treat pain. There is usually no end of treatment, and there is usually we can do something more instead of telling the patient just live with it, because we got when we do lots of pain. When we see lots of pain patients, we always get these patients who are told that just live with your pain, there is nothing else that can be done. So what we can stress here now is, yes, there are things that can be done. Maybe more invasive, maybe more major procedures, but yes, we have lots of things that can be done, and we have lots of ways to help the patients. So I would like to thank our panelists, Professor Geber. I would like to thank our speakers, Professor Alish, Dr. Dina, and I would like to thank Saudi German Hospital Group for hosting us. Actually, we are Saudi German Hospital Group, so thank you, everybody. And
Dr. Ayman, I just want to conclude by thanking everyone, Professor Alish and our distinguished panel, and thank our participant, Professor Zoe Valmaki, our oncosurgeon. She's attending and sending question. Really, I'm excited that having a professor from UK attending our webinar today. And you can see like 16 countries, are presented in our audience. That, as you said, as Professor Alish, they started and they did not leave the room. It means that we are doing something exciting. So I want really to thank all the panel and the perfect moderation from Dr. Ayman and the contribution from Dr. Hassan and Dr. Dina. And I just want to remind our audience that the CME, because there are many questions related to CME hours. CME hours, it takes some time to be uploaded to your account. You can follow up with our CME coordinator, Mr. Saleh Al-Saidi. His email is posted on the chat, so you can contact him. Sometimes there is a wrong registration number or wrong information, maybe need to be corrected. But anyway, as you said, today program is 2 hours accredited. We expect that the names will be uploaded within a week or 10 days. If it's not, you can contact Mr. Saleh to sort out any issues related to your CME. I want to thank all of you, and we are looking forward to see you on our coming webinar. We have a webinar on rare conditions in pediatrics on Friday. We have another webinar with Dr. Dina and the Saudi Pain Management Society on Saturday about low back pain management. On Sunday, we have an interesting webinar with Professor Webster. He is our international visiting professor in urology, about endoscopy in urology. So please keep yourself engaged with us. You will have many exciting webinars to come on. Thank you very much. Thank you very much, Professor Alish and the dear panel. Thank you.